Hello, ladies and gentlemen. I will give a talk about the fluid accumulation syndrome. These are my conflicts of interest, and only recently I moved to the Jan Palfijn Hospital in Ghent, which is a beautiful hospital situated at the waterfront as chief medical officer. So if water is the problem, then we need to avoid fluid accumulation. So de-resuscitation, fluid removal may be the solution. I'm very fortunate to have met Mathilde Her Majesty, Queen of the Belgians, as well as King Philip when he was visiting our hospital during the first wave of the COVID pandemic, as well as Maggie, the former Belgian Minister of Healthcare. But my topic today will be about breaking some bad habits. So we know that sepsis is a killer. On an annual basis, over 258,000 patients die in the US from sepsis. And this is more than other diseases like AIDS or cancers. And we look at the evolution of sepsis mortality. We see in blue evolution in Australia and in red in the US. And you see after the introduction of the Surviving Sepsis Campaign guidelines, there is not much of a change in the natural history of sepsis mortality. So sepsis has been redefined by the Sepsis 3.0 definitions as an infection plus organ dysfunction. So it's a dysregulated host response on the infection, and the organ dysfunction can be quantified like with a quick SOFA. So to sum up, it's a dysregulated host response. Initially, there was a 3-hour sepsis bundle, and it was recommended to start 30 ml per kilo within the first 3 hours, although it was a strong recommendation. It was low quality of evidence, rather no evidence. Where does this come from? From the blue stage of spasmodic cholera, where we saw that giving intravenous fluids resulted in better outcomes and could save lives. Although we know that when we give fluids or fluid boluses, the effects on cardiac index are only short-lasting. And some studies like study of the FEAST trial showed that children who were given boluses of albumin or saline had a poor prognosis. So 30 ml per kilo in 3 hours, may this lead to peripheral edema, anasarcanus? This cosmetic or bad medicine? If you follow the guidelines, whichever path you follow at the end, the advice will be to start a rapid infusion of 30 ml per kilo of crystalloids. So if you'd ask on social media, for instance in Twitter, that many colleagues don't support or don't agree to the Surviving Sepsis guidelines. In fact, it's the majority that does not support or does not adhere to this fluid loading of 30 ml per kilo. In 2018, there was an update. And now the fluid administration should be given within the first 1 hour. So we do have a 1 hour bundle now, and it has been added that early vasopressors could be given if the patient remains hypotensive. So 30 ml per kilo in 1 hour, is this good medicine, or is this a state of complete and utter madness? Because if you would be a regular patient in the US, obesity, 155 kilo, you would need 4.6 liters to be started within the first hour. If you don't do so, live in the state of New York, the step 1 mandate, you may go to High Court for malpractice. But if you do so, you may induce fluid accumulation or fluid overloads. So it's all about fluids as drugs. I will give you a conceptual framework looking at definitions, diagnosis, the drug, the dose, the duration, the de-escalation, and then what about discharge? So are there any key measures we can take? So if we have D1 multiplied to D7, we have D to the power of 7, and this is what I would refer to as fluid stewardship, and this is what we should be doing. I'm not going to bore you with a lot of definitions, nor will I give any overload, but let's focus on the most important ones. Fluid balance is the sum of the intakes and the outputs. Fluid overload, you can calculate it by dividing the cumulative fluid balance in liters by the baseline body weight, and it's defined by a cutoff value of a 10% increase of fluid accumulation. Early adequate goal-directed fluid management, this is what the Surviving Sepsis campaign refers to. Late conservative fluid management is 2 consecutive days of negative fluid balance within the first week of ICU stay, and a late goal-directed fluid removal. This is what we refer to some as de-escalation, but I prefer de-resuscitation because it's active. You use diuretics or renal replacement therapy with ultrafiltration. So while fluid overload may lead to hypervolemia, hyperhydration, and peripheral edema, we know that hypervolemia will result in peripheral edema, but peripheral edema does not necessarily mean that the patient is hypervolemic. So maybe we should avoid the term fluid overload and replace it by fluid accumulation, as is suggested by Jean-Louis Vincent. So there are many more definitions, and I'm not going into detail now, but I will allude to them during the rest of my talk. So D2 is on the diagnosis, and we know that hypovolemia may be detrimental, as there may be a convective problem and oxygen can't get to the tissues. But hypervolemia is also bad because this leads to a diffusion problem. You will have interstitial edema. One of my favorites is increased intra-abdominal pressure. So this should be avoided at all times. Therefore, fluid status matters. And there are a lot of myths regarding fluid therapy and fluid status, as septic patients are not always hypovolemic. Surgical patients are not always hypovolemic. Sepsis does not mean that there are always huge insensible losses. And peripheral edema does not mean that the patient is fluid overloaded and is in need for diuretics. A low preload does not mean that we need to give fluids, because sepsis, in the initial phase, patients are not hypovolemic, they may be vasoplegic. So what about these 4 questions that we need to ask and treat fluids as a drug? Of course, we must avoid harming the patient. So the first question is when to start fluids, because the best fluid is the one that has not been given unnecessary. Second question is when to stop fluids, when they're no longer needed, when the patient has an oral intake. And then some patients may need a little help, and we might ask ourselves when to start fluid removal. And of course, when you're removing fluids, you must at some point stop to avoid hypoperfusion. And this active fluid removal is de-resuscitation. So if you would sum up all the literature, surgical trauma patients, starches are probably not a good choice. Not much data on gelatins. Saline in large amounts is not a good option, nor hypotonic solutions. So balanced crystalloids form a good first choice. And the same holds true in septic patients or patients in the ICU. Of course, blood can be given when it's needed, taken into account the shelf life. And there may be a place for albumin 20% at the later stages for mobilization of interstitial fluids and de-resuscitation. But again, the fluid strategy is more important than the fluid itself. Only 4 indications to give fluids, one being resuscitation fluids, and those received most of the attention in the literature, and the largest part, however, of the fluids that we give to our patients are from another type, as in this study by Niels van Regemel, about 15,000 patients, 100,000 patient days, and they found that only 6% of fluids given are for resuscitation, 25% maintenance, 33% nutrition, and another 33% is fluid creep, fluid that seeps into the patient because we need to administer antibiotics, pain killers, and so forth. So brings me to T4, which is the dose. And Paracelsus nicely stated that all things are poison, and it's the dose that makes something to become poisonous. Key concept of pharmacokinetics and pharmacodynamics we know very well from antibiotics and antibiotic stewardship, where the pharmacokinetics is how the drug interacts with the host, and the pharmacodynamics is how the drug interacts on the back. The same holds true for fluids. D5 is on duration, and of course, we should not use fluids to treat the numbers like a low CVP, low blood pressure, low urine output, but we need to use fluids to treat shock. D6 on de-escalation, which brings me to the 4 phases of intravenous fluid therapy, conceptual models that have been presented by the ATKI, Critical Investigator Group, and at the same time in 2014, another paper came out. If you ask On social media, there is a clear preference to use the ROSE acronym instead of SOSD because it's much easier to pronounce. So when you resuscitate, you have the blossoming, you save lives, and then you support the organs, you stabilize the patient, and at some point we need to evacuate the excess of fluids, hence the acronym ROSE. So it has to be stated that after the first hit, after giving fluids to the patient, fluid balance should be positive, then we have a neutral balance, and then we evacuate. So just to mention that the ROSE at the end is just a dry one, it's not that patient. And I'm very happy to see that this ROSE concept has been picked up by other colleagues as well. So if we look at the current literature data, we plot this on a timeline. Some studies focus on it very early, but the big fluid trials, they randomize patients after 12 to 24 hours, so after the initial resuscitation phase. So it's very difficult to translate this for each and every individual patient because there is no one single study covering all the phases. So first, we give fluids, we rescue the patient with goal-directed therapy, we optimize organ function, late conservative fluid management, we stabilize the patient early, late goal-directed fluid removal, we evacuate the excess of fluids, and we hope to save the patients. Initially, we guide on macro hemodynamics like blood pressure or volumetric preload, and of course, fluid responsiveness with the passive electricity. These normalize, we stop giving fluids. And if there is an impact of fluid accumulation on end organ function, we may need to remove the excess of fluids. We need to identify the right targets in order to reach the right goal, which is to avoid a global increased permeability syndrome. Because when we give fluids, there will be second and third space fluid accumulation. Intra-abdominal pressure will increase with bowel edema, ileus, compression of the vena cava, reduced blood flow to the heart, with a reduced cardiac output and reduced flow to all the organs. And this may trigger a vicious cycle of multi-system organ dysfunction and failure. So we know that a positive fluid balance is an independent prognostic factor patient with sepsis. If you compare restrictive and liberal treatments, you see that mortality is worse in liberal fluid management because the fluid will accumulate and fluid overload will be manifested at the outside, the anasarcedema, peripheral edema, but this will mirror fluid accumulation at the inside. In each and every organ, there will be venous congestion and organ dysfunction. And this is what we refer to as the global increased permeability syndrome. And this happens in the brain where you can have cerebral edema, delirium, increased intracranial pressures, and so forth with diminished cerebral perfusion pressure. Just to show you some data of a pig study where they were randomized liberal or restrictive fluids, and it was found that cerebral edema was indicated by cortical water content. The volume of fluid infused and fluid balance did affect the intracranial pressure. And in some patients with severe burn and trauma, given large amounts of fluids, it was seen that fluid accumulation may also lead to intraorbital pressure increase, IOP, and patients that were in need for a decompression received much more fluids. So this can cause an intraorbital compartment syndrome. What happens with the respiratory system is the same story, fluid accumulation, pleural effusion. You get a stiff chest wall, increases in extravascular lung water, poor oxygenation and ventilation, difficult weaning. We have the FACT trial comparing two fluid management strategies, liberal, so after 1 week, +7 liters, conservative, neutral balance, and albeit the fact that there was no difference in mortality, there was some signal that there was better lung function. What happens with fluid accumulation? Cardiovascular system, same story. Myocardial edema, you get conduction, contractility, disturbances, diastolic dysfunction, increased filling pressures, diminished venous return, you get venous congestion and myocardial depression. In the study of myocardial edema in 25 dogs, it was induced by progressive bedding of the pulmonary artery with interstitial fluid pressures that were followed in cardiac compliance. You see, the more extravascular fluid, the lower the cardiac compliance. For the kidneys, it's the same story. You get interstitial edema, renal venous pressure increases, renal blood flow diminishes, and you get water and salt retention. You can also have a local renal compartment syndrome. The study looking at the positive fluid balance in association to AKI, again, it's the same story that a positive fluid balance increases the relative risk for AKI. Also found in the finicky trial, the ones with fluid overload, poor survival. There was also clear relation between the amount of fluid accumulation and 90-day mortality. Presence of fluid overload was an independent predictor. And also the renal study showed that non-survivors had a more positive fluid balance as compared to survivors. And other studies over and over show the same results. Patients with fluid overload have less probability of survival. Other interesting thing is that fluid accumulation may have an impact on the recognition staging of AKI in critically ill patients, probably because of dilution. Creatinine values are lowered, and these are used for the AKIN definitions. So the day of AKI during the observation was related to the cumulative fluid balance. Gastrointestinal system, same story, gut edema, intra-abdominal hypertension, ascites, diminished bowel contractility, ileus, and maybe even permeability and bacterial translocation. In our study, observational, we saw that a negative fluid balance by day 3 carried a good prognosis, and non-survivors had a higher cumulative fluid balance. Effect of the type of fluid resuscitation may have an impact on gut edema if you compare colloids and crystalloids. Crystalloids will lead to a higher gut wet to dry ratio, and this gut edema may lead to diminished contractility in blue. Question is whether all this is also relevant in COVID-19. Absolutely yes, because we know that these patients are prone to fluid accumulation because of the capillary leak. I believe that anasarca is not cosmetic, but it may be bad medicine. So the question then is, when should we give these patients little help and go for deresuscitation? Well, when the patient is not transgressing spontaneously from the ebb to the flow phase and is keeping fluids on board. So these are the patients that we may think of, especially if there is an impact of fluid accumulation on end organ function as defined by a persistent global increased permeability syndrome. So GIPS is a persistent positive cumulative fluid balance plus new onset organ failure and dysfunction, mostly evidenced by a drop in PF ratio, a high lung water, high pulmonary vascular permeability, and a high intra-abdominal pressure. So to identify the right patient that may benefit from deresuscitation, we need to individualize our treatment. So the question is how to assess hypervolemia, or how to guide deresuscitation. So you can have clinical assessment, just looking at body weight or fluid balance, or other signs and symptoms, peripheral edema, and so forth. But these are rather aspecific. There are also biochemical assessment of fluid overload, which could be related to a drop in albumin or protein, or a drop in hematocrit because of dilution. Interesting parameter may be the capillary leak index, CRP divided by albumin. Also radiological assessment on plain X-ray or on ultrasound. And I think that ultrasound may be the stethoscope, the modern stethoscope, looking at inferior vena cava, collapsibility index. If you would show this and you would ask on social media again, what is the fluid status, then you see there is no clear-cut answer, because in fact, this dilated inferior vena cava was a result of cardiac tamponade. So the patient, in fact, was underfilled, and the drop in inferior vena collapsibility index with the distended inferior vena cava was not a result of hypovolemia and fluid responsiveness. But of course, if you use these modern techniques, you need to be aware of the pitfalls and the limitation. And abdominal hypertension, right ventricular failure may also have an impact, as well as auto-PEEP, or positive pressure ventilation on the inferior vena cava. So I don't think that a low inferior vena cava collapsibility does mean that the patient is fluid overloaded, but there are many other reasons to use ultrasound at the bedside. You could look for B lines, amongst others. So clinical factors of fluid accumulation, biochemical and imaging are rather aspecific, and now let's focus on hemodynamic factors, impact on organ function, and maybe some interesting ideas for the future. So what about hemodynamic assessment of fluid overload? You could look at filling pressure, volumetric preload. The absence of fluid responsiveness may be an interesting one, and I will focus just on these, because the passive leg raising test may guide fluid removal in critically ill patients. So these are patients who are going to dialysis, and you can see that in the patients with intradialytic hypotension, you see that there is a drop in cardiac index, but you see that there is a positive effect of the passive leg raising test. So the ones who don't have an increase with the passive leg raising test are the ones that will support fluid removal. Next, what about volumetric preload parameters? Because the thing is that if you have a low ejection fraction, you will have a higher resting value compared to if you have a good heart and a good ejection fraction. So correcting the volumetric parameters in relation to the ejection fraction may help us. And you see on the right, when you use the corrected volumes, you see better the trend if you would administer diuretics and remove net 1 liter out of the patient. The impact of fluid accumulation on end organ function, as stated before, all organ functions are affected, but most interesting with regard to monitoring may be the lungs with lung water, PVPI, and the GI tract with abdominal pressure. So what about high lung water? In this study, about 123 patients, we saw that a drop in the lung water carried a good prognosis. So if you would define responders, the ones who are dropping the lung water, and the non-responders, the ones that are increasing, you see that this is related to cumulative fluid balance. If we then apply late conservative fluid management, you see that there is better survival and faster weaning. But if you also look at responders, so the ones who have a drop in the lung water, it's better survival and faster weaning. So another parameter may be the pulmonary vascular permeability index, which is the ratio between lung water and pulmonary blood volume, which is higher in hyperpermeability edema compared to hydrostatic edema. And Mona and co-workers were able to separate capillary leak pulmonary edema from hydrostatic permeability indicator of 3. So this may be an interesting parameter, as well as abdominal pressure, where you can see that fluid removal with a net fluid loss around 2 liters resulted in a drop in abdominal pressure, drop in volumetric preload, and lung water. So what will the future bring us? Maybe other interesting ideas, and I would like to focus on bioelectrical impedance analysis, as well as assessment of total circulating blood volume and VEXUS. So what about bioelectrical impedance analysis, and especially the ratio between extracellular and intracellular water? Let me illustrate this with a case of a trauma patient, positive fluid balance of +5 liters and a poor PF ratio and a high lung water. And you see with this technique, you can assess the volume excess. This correlated with a chest X-ray. Now we started on recruitment with high-frequency percussive ventilation and some diuretics, and you see on the next stage lungs are cleared, and fluid balance with the volume excess dropped with the diuretics. And then you usually see that the patient will not respond to diuretics, and then you may need some ultrafiltration with continuous CVVH, and you see that over time the fluid balance became back to normal. And with this modern techniques, you know, calculate KT/C. You can visualize the progression of the extracellular water, and you can see that the patient came from the edematous status to normal volemic status. We looked at this in ICU patients and healthy patients, and you see that ICU patients have a volume excess and have this increased ratio between extracellular, intracellular water, which may be interesting parameters. And this study has been published recently, is available under open access. If we then compare survivors and non-survivors of the ICU patients, it's the same signal where you see that non-survivors have higher volume excess and a higher ratio between extracellular and intracellular. So this may be interesting for the future. And then another promising technique is with isotope labeling the albumin with calculation of total circulating blood volume. So you have to withdraw some blood. You have to trace it with iodine 131. The albumin you inject again, and then you take blood samples every 6 minutes, and you can construct back, depending on the capillary leak, the total circulating blood volume. I found one study using this technique in septic patients where they saw that less fluid was given, more diuretics, and this resulted in a reduction in mortality and length of stay. So one more thing I would like to mention is what I already alluded to with the impact of fluid accumulation on end-organ function, which is the venous congestion. There's been interesting work by Philip Rolla looking at VAXUS, which is venous congestion by ultrasound, looking at hepatic portal and intrarenal venous Doppler, and then quantifying a score with a grading system, and using that score, it's much more better to predict severe congestion in opposition to using, for instance, CVP. So I think this will be promising in the future. If you want to learn more on fluid accumulation, there are lots of publications available as open access, or otherwise just send me an email and I will send the PDFs. One very last more thing is how then do we do this deresuscitation? For this, you could use a furosemide stress test, which is giving a small dose of furosemide, and this has been used by nephrologists to predict AKI and look at tubular reserve. If your output is less than 200 mL after 2 hours, then this is a strong predictor for AKI. And I would suggest maybe you're ready for deresuscitation tests, a very slight dose, and then you look at the urine production and the slope of this curve. For this, you would need continuous urine output. Another option is to use PAL treatment, which is a combination of PEEP, the PEEP set equal to the intra-abdominal pressure. You squeeze the fluids out of the alveolus into the interstitium, increasing interstitial hydrostatic pressure, where you force the fluids into the intravascular space by adding the hyperonchotic albumin, and then followed by the furosemide. You can clear the fluids out of the lungs, out of the patients. So each step will take about 30 minutes to equalize. And we looked at this in a pilot study. So the PAL group received more PEEP, more albumin, because it was substituted. And after 1 week of treatment, you see that there is better impact on abdominal pressure, lung water, and this by reducing the cumulative fluid balance resulted in a better survival and a faster weaning. Other studies looking at late conservative fluid therapy, like the classic pilot trial, you see that mortality seems to be best if you have early conservative and late conservative fluid management, rather than liberal initially, goal-directed, and liberal all the way. And you can read more about this liberal versus restrictive strategies in an open access paper published in Intensive Care. So the last thing I would like to mention is that once the patient is discharged, I think it's important that you follow up your fluid strategy and implement fluid stewardship, which is a series of coordinated interventions introduced to select optimal fluid dose and duration of therapy that results in the best clinical outcome and prevention of adverse events and cost reduction. So I just want to share with you 2 slides what happened in Brussels, where we implemented fluid stewardship in 2017, and you see that the IV fluid consumption per patient admission dropped with 1.5 liters, and the amount of fluids given per patient day also dropped from 0.6 to 0.4. So I think it's feasible to do so. So, ladies and gentlemen, to wrap things up, I hope I convinced you that IV fluids are not just innocent bags of water, but they should be treated as any other drug. They come with indications, contraindications, adverse effects. So think about the drug dose, duration, de-escalation. So set up your fluid team, think about the definitions, the diagnosis, all about drug with the questions and the indications, adverse effects. For these, with the dose, the pharmacokinetics, dynamics, duration, de-escalation, the ROSE concept with the 4 phases, and then 4 hits I mentioned a little bit, and then about discharge, which is the implementation of fluid stewardship. So I think it's about time, set up your fluid team and start fluidship in your hospital, in your ICU now by identifying doctors and nurses. So I'd like you to take home that fluid overload is defined by a cutoff value of 10% increase of body weight of fluid accumulation. And maybe fluid accumulation is a better term. It's associated with increased morbidity, length of stay, ventilator days, mortality, and with end-organ failure. And this is the global increased permeability syndrome. All organs are affected, and it's the absence of transition from the ebb to the flow phase of shock. How to guide de-resuscitation, clinical lab science, a specific static imaging, a specific use point of care ultrasound, know the limits of inferior vena-cava collapsibility index. Volumetric preload is much better. The absence of fluid responsiveness, like a negative passive lag raise, may be an indicator for de-resuscitation. Assess the impact of fluid accumulation on end organ function. There are some promising techniques, while it's de-resuscitation, avoid hypoperfusion. And I think bioelectrical impedance analysis, circulating blood volume with isotope dilution techniques. I didn't talk about EIT, but don't forget venous congestion and have a look at the VEXA score. Having said that, I would like to invite you to join the International Fluid Academy with a free lifetime membership. Thank you for your attention.
Well, thank you very much, Dr. Malbrain. Excellent speech. Pasamos ahora a, en realidad muy conceptual, muy amplia, así que creo que contestó la mayoría de las preguntas que se le pueden hacer. Vamos a ver si hay alguna pregunta del público y si no, me gustaría preguntarle alguna cosa en particular. Por ahora no tenemos preguntas del público, así que la pregunta que me gustaría hacer es muy amplia, obviamente, pero en base a su experiencia, la evidencia actual y su uso clínico habitual, ¿cuál es el lugar de la albúmina en este momento? ¿En qué etapa? ¿Qué tipo de concentración de albúmina y en qué dosis, si es que usted la recomienda utilizar? Creo que por lo que ha dicho en algunos casos en particular, obviamente es siempre un tratamiento individualizado. Pero ¿a qué tipo de pacientes usted diría que en base a su costo deberíamos emplearlo?
Was this a question? Is it possible to translate in English?
Yes, maybe the use of albumin, which is the indication, the formal indication you consider now with the evidence we have and in your practical use in your clinical working.
Yeah. So there is not much hard evidence. If you look at the Albios trial in the subgroup of severe sepsis septic shock, there was some advantage of using hyper-oncotic albumin, 20% in the later phase. How we do it in clinical practice is you only need to de-resuscitate when there are clinical signs and symptoms and impact of fluid overload on end organ function, because some patients will have a positive balance and won't have any issues with organ function, and they will evacuate the excess of fluid spontaneously, like you see in tubular necrosis when you have a polyuric phase and the patient evacuates spontaneously. I would suggest to give hypertonic albumin in case the albumin levels are low, below 30 grams per liter. and then in combination with furosemide, and you wait 30 minutes between the different stages of your deresuscitation therapy to allow for equilibration between the different body compartments. I don't see any place for hypo-oncotic albumin, 4% or even 5%, as I think there is no hard evidence to use those solutions.
Well, thank you. We have any question? ¿Tenemos alguna pregunta del público? Si no, me gustaría capaz que hacer otra pregunta. Sobre el uso de diuréticos, sobre todo en la etapa de evacuación, ¿no? Que es su indicación principal. Habitualmente hablamos del furosemide, las formas de infusión, más o menos usted hizo una descripción en su presentación. ¿Tienen otro tipo de diuréticos? ¿Alguna indicación puntual en su asociación? Y si es así, ¿para qué tipo de pacientes los emplea o los recomienda?
So, if I can translate from, I think the question is if there are other types of diuretics.
Yes, other types of diuretics for the evacuation stage, when you recommend to use it, and in which particular case, if you recommend it.
Yeah, I think it's a very good question, because with furosemide alone, you may not reach the necessary amount of fluid removal. So I think it's a very good point, and sometimes you need to have a combination of diuretics with acetazolamide, maybe with spironolactone, or even with indapamide if you have high sodium levels. So I think a combination of diuretics may have a synergistic effect. But usually you may see that this will only work for 1 or 2 days, and that sometimes you may need hemofiltration with active fluid removal, ultrafiltration. But then comes the question, when can you do this in a safe way? Because we must avoid intravascular hypovolemia, hypoperfusion, which may then cause more problems. And for that, I think performing a passive leg raising test, and when you don't see an increase in blood pressure as a surrogate for cardiac output, then you may be safe with fluid removal. And this is from the study from Xavier Monet, when they're using dialysis and fluid removal, and if the passive leg raising test is negative, those patients support fluid removal. So I think it's not this or this or this parameter, it's a holistic approach, and you have different monitoring tools and tests in order to perform deresuscitation safely. But I must say that until today, there is no big randomized controlled trial showing that restrictive versus liberal fluid therapy has an impact on outcome. But the problem is, and there has just been a recent meta-analysis, is if you compare the studies that randomized between restrictive and liberal, at the end, there is no clear separation in fluid balance. So you may say that we are restrictive and we're giving diuretics, but the end result is that the fluid balance and the cumulative fluid balance, there is still a big overlap in between the groups. So it's not so easy to perform this kind of study in real life.